Good afternoon, everyone. Thank you so much for joining us this wonderful Tuesday afternoon for our Ask the Expert, How Palliative Care Can Help Caregivers Help Themselves. As we wait for folks to trickle in, I just want to set a few reminders. I ask that you please mute yourself during the duration of the presentation. Any questions that you may have, we're encouraging folks to please share them in the chat. If I do have anyone who is tuning in using the audio or the call in option, again, I do please ask that you wait towards the end of the presentation to share your questions. Again, for anyone who is participating via phone, at the end of the presentation during the Q&A portion, you can unmute yourself by uh, using the *7 on your phone's keyboard. Again, thank you everyone for joining us. As we wait for folks to continue to trickle in, we're going to go ahead and talk a little bit about the Alzheimer's Association before we introduce our guest speakers, Dr. Esch and Dr. Newman. So I wanted to take a moment to share a little bit more information on the facts and figures about Alzheimer's disease and consider how widespread the impact of Alzheimer's disease and dementia can be. So as you can see in our latest facts and figures, nearly 7 million Americans are living with Alzheimer's. Over 11 million are providing unpaid care for people living with the disease. And we do know that our Black and Latino communities are very impacted by this disease. We see that Black Americans are twice as likely to develop Alzheimer's. Hispanic Americans are 1.5 times more likely to develop Alzheimer's. And we also know that Alzheimer's disproportionately impacts women. If left unchecked, Alzheimer's will continue to impact our finances, our families, and our future. So the Alzheimer's Association, our mission is to lead the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. We're here to provide community for both caregivers and community members who might be navigating this disease. We are also committed to ensuring that health equity is at the center of the work that we do, meaning that we believe that all communities have a fair and just opportunity to an early diagnosis and access to risk reduction and quality care. The Alzheimer's Association is committed to engaging our underrepresented and underserved and historically marginalized communities and responding with resources and education to address the disproportionate impact of Alzheimer's and dementia. So very briefly, before I turn it over to our guest speakers, I do want to mention that we have a 24/7 helpline that's here to provide you support. Again, 24 hours a day, 7 days a week. We have care specialists that speak over 200 different languages. We're here to provide that support to you that you might need in your journey. We offer a number of free educational programs, peer-to-peer led support groups, and we have chapters across the country. Please know that you will receive an email from me at the end of this presentation with all of this information. So now, let's get started with our special program, How Palliative Care Can Help Caregivers Take Care of Themselves. So it's with great honor that I'd like to introduce our guest speakers. So Dr. Sharika Newman is a distinguished graduate of Florida A&M University and a board-certified family medicine physician with added qualifications in hospice and palliative medicine through fellowship training. She founded Doctor in the Family to partner with patients and their families to help navigate the complexities of healthcare. Dr. Newman's mission is to provide everyone with access to a trusted doctor in the family ready to assist with medical questions and guidance. We also have Dr. Esch, the Director of Palliative Care Program Development at the Center of Advanced Palliative Care. Dr. Ash earned his medical degree from the University of Buffalo, where he also earned a combined Bachelor's of Science and an MBA. Dr. Ash was medical director of palliative care at the Lee Memorial Health System, and he speaks nationally on palliative care for doctors and patients and caregivers. Dr. Newman, Dr. Ash, thank you so much for joining us today.
Thanks for having me.
Yeah, thanks for having us. And I just want to thank the Alzheimer's Association, specifically the New York City chapter, for having us on here. Sharika and I we've worked together a long time. We're really comfortable. Um, presenting. We're really comfortable with each other. And I say this because if you have questions during this, just drop them in the chat box. I'll open it up and I'll keep an eye on it. We don't want to get too far ahead. We're here for you. So whatever questions you have, we'll leave time at the end for sure. But if you don't understand something or you want more, just type something in the chat and we'll interrupt it and be nimble to do this. We can go on to the next slide. I think we're going to talk here about our objectives for the for today. And while I'm doing this, I was hoping if you have access to the chat function, maybe just drop in what your role is on being here. For example, are you a caregiver? Are you a patient? Are you a care coordinator? If just in a word or two, just drop in what your what your role is and your interest in today's agenda, which is we just want to really describe what palliative care is and how it can help people who are living with dementia, and not just the patients living with dementia, their caregivers as well. We'll outline some of the benefits of palliative care, and how to help caregivers take advantage of these benefits and help themselves. And then we'll review some resources and how to get information on palliative care. We can go to the next slide. So we'll start with what is palliative care, and we can go to the next slide right away. Palliative care really is specialized medical care for people living with serious illnesses like dementia. Our focus in palliative care is to work with all the other people involved in the patient's care, but with a focus on relieving the symptoms and stress of serious illness. The ultimate goal is to improve the quality of life for both the patient and the family. And Sharika, we've both been doing this for a long time. I mean, I think the key to a slide like this is that we're trying to focus on the improvement of quality of life, but we still want people to get all treatments that are relevant.
Correct. We definitely, I call it like a co-management when you're going through something serious, and we focus on quality while your neurologist will focus on the dementia part of it. And I think my biggest thing that I always echo is that for palliative physicians or the palliative care team, we look at the patient and family as one unit. Or the patient and whoever's caring for them as one unit, because we've recognized that someone living with serious illness needs support beyond just themselves. And it's important to include that support in the treatment unit.
Thank you. We can go to the next slide. So yeah, again, specialty care, and it's provided with all the other care that you may already be getting. And I know that sounds like, whoa, the last thing we need is another doctor in the mix. But I think one of the things that palliative care does is that we can get involved at really any stage in the Alzheimer's or other serious illnesses. And we do this alongside other curable treatment, again, focusing on the experience of living with the illness and trying to make that as least problematic and high quality as it can be. And so, in an illness like dementia, which people live with for many, many years, I think somewhere between 8 and 10 years is kind of the average now that people live with it. There's a lot of potential for positive interactions between palliative care and the other providers to improve outcomes and improve quality of life. We can go to the next slide. So, why palliative care? Sharika, I'm curious. We try to hit the highlights here, but I'm curious to know what your opinion is on why palliative care for people. But it's about improving quality of life. Um, there's often other medical conditions that happen alongside dementia, and we can help with the symptoms and the sort of issues that come up with that. And we do know that early integration of palliative care along with disease targeted treatment can really help improve better outcomes.
Yeah, I think for me, I would say if I say the layman's why is twofold for me. One, I think patients and families sometimes don't know what they don't know, and they don't know to even ask certain things. And palliative care at least jogs people's memory or provokes them to think of certain things that they haven't thought of. And the other thing that I think it does, and along with improving quality of life, is it does that to me by including the patient in the selection and the decision, right? A lot of times, I know Andy, you and I've talked about this. We hear patients say, um, they're not listening to me. I feel like everyone's talking above me, things like that. And I don't know if anyone has ever experienced that where you are trying to convey something to someone and you feel unheard. A lot of times, palliative care improves the quality because we help the patient and the family get heard with the medical team by coordinating that care and having that dialogue. And so I think it's important if you have someone with serious illness that palliative care gets involved as early as possible so that we can kind of keep you involved, like keep your desires involved in the care.
Yeah.
Next slide.
Yeah, I just want to address Michelle's question. I saw you typed into the chat, Sharika, but ask, would you say that would you say these patients who may have an incurable illness? And I think that's a good point. I mean, I think in palliative care, we treat three groups of patients. We treat patients that get diagnosed with a serious illness that may be curable, and we sort of walk that path with them on their way to cure, help manage the symptoms of treatment and things like that. I'd say the vast majority of patients that we get involved with have illnesses that may not be curable, but they live with disease for a long time, and I would say Alzheimer's falls into this.
And
Dementia.
that's what I mean by treatable, by the way, meaning it's not curable, but it's treatable. Like we can treat what's going on with them, but we can't take it away.
Yep. And I'd say those are the two biggest groups that we treat. Some go on to have pretty rapid illnesses that will cause them to succumb to their illness, but the majority of the patients are kind of that middle group that they live with these illnesses for a long time. And so the benefits of palliative care in a patient that's living with a chronic illness for a long period of time, years in the quality of life for not just the patient, but also their caregiver, um, helps match treatment options to goals. Um, if palliative care is involved, there's usually a team of specialty trained people. Like Sharika, you may have, I know your skill set's a little broader in different ways than mine, but I really struggle if people are having spiritual issues in the face of their illness. I'm not I think I'm a good physician, but I'm not a great social worker. So I can't navigate sort of the healthcare system and community resources like a social worker does.
Right.
So the spirit of palliative care is to bring, those folks together to try to address the complex issues that people experience while they're going through illness.
And it's because people, I mean, serious illness, I'm sure as many of you on the line have experienced, it impacts every aspect of who we are as a being, our mind, body, spirit. It impacts our family and our finances and our social constructs. And so, like Andy said, we're good doctors, but we're not good social workers. We're not good chaplains. We're not neither at all, more or less good at it. So it's so important. I know Andy and I have valued the input of our teammates who do the social work and spiritual care. I remember this very challenging case we had at Lee around spirituality. And boy, we were so happy to get the spiritual team involved because Andy and I were very stuck. And I think we couldn't see the depths of the spiritual barrier to care for that patient. And so it's important that you have specialists beyond your doctor and maybe your nurse or nurse practitioner when you have something serious, because all aspects of who you are can be impacted.
Yeah, yeah, that's well put. We can go to the next slide. I'll just say in wrapping up kind of that slide is Why did this happen to me is a spiritual question, not a scientific one. People don't want to hear about aluminum and causes and things like that. They want to know, like, why in this world is this happening to me? And that a lot of times the answers for palliative care are in spiritual or the social work aspects of the care. So, um, which brings us to, how do people perceive and understand palliative care? And Sharika and I have spent probably all of our careers really making education about what palliative care is a big part of what we do. So, there was, public opinion research done that asked, people what they understood about palliative care. And uh, the initial responses were that people didn't really understand much about it at all, but then they were given definitions and they were explained what palliative care is, kind of the stuff we talked about at the beginning of this, how it's a group of specialists that work with your other doctors to help improve quality of life and give an extra layer of support. And once people were told what it was, 90% were really positive about it and they would likely consider palliative care. 94% believe that patients should have access to palliative care. And the vast majority, over three-quarters, felt strongly that it's important that patients, their families, be educated about palliative care and that it's available along with curative treatment. So, Shriek, I know educating colleagues, educating the public has been a big part of your practice as well. And I'm just wondering if you have other things to add around this.
I think we've come, Andy, if you think about it, you and I have been at this at a while, we've come such a long way around this topic, right? Like people at least can say the word, and a number of people now understand its utilization, whether it's, community or our colleagues in medicine. So I'm glad that we have come as far as we've come. I feel like post COVID, we definitely people got a better understanding. I felt like the pandemic kind of magnify the role of palliative care. And once people, what this study and these, what I'm talking about, what it shows is when people are educated on what palliative care is and what it does for someone with serious illness, people want it. So it's not something patients and families don't want. It's just things people don't know about.
We can go on to the next slide. So it looked to me from the informal survey we did in the chat that we have a lot of caregivers, some support group coordinators, caregiver coordinators, family members, and past caregivers. So, I mean, I'm not going to tell you anything you don't know on this slide. There's, living with dementia comes with challenges, not just for the patient, but the caregiver as well. And so, I won't read every box to you, but, you know, I think the thing that strikes me when I look at this is that these are pretty common things. But when you have pain, or constipation or eating problems, like things that don't seem like big deals, you do that with somebody who's having difficulty communicating what they're feeling, that communication comes out as behaviors. And I think one of the real aha moments for me in doing palliative care and taking care of patients with dementia is this idea that behavior is communication. And so if I have a dementia patient that's having quote unquote behaviors, I don't think about, do I treat the behavior? I think about a box like this. Are they constipated? Are they in pain? Are they in nausea? Are they nauseous? What are they trying to tell me? Sharika, do you incorporate
I,
that sort of thinking
I
into your?
mean, behaviors is communication is something I'm going to steal from you, Andy. Man, that just resonated with me. I see it as this is like a baby's cry, right? And when we all had our kids, when they start crying, we did are they hungry? Are they wet? Is it a diaper issue? Do they just need holding and coddling? And so I think it's good to extrapolate that out, that this behavior is actually a form of communication for the person living with dementia, because it really robs the patient of their memories, including functional things, right? Like how to use the bathroom and how to swallow and where I put my toothbrush and where I go to the bathroom. It really robs people of those things. And this is the only way they can express it. I just recalled a time where my mom came to visit me. My mom has had dementia. But when she came to visit me, because it was a new home, she was peeing in the wrong place for 3 days. I actually thought a pipe busted in the wall, to be honest with you, but it wasn't. It was her using the bathroom. And it was just a behavioral change because there was a change in location for her, right? And so that's part of dementia too. And it can be frustrating. I find these things hilarious because that's who I am. I find humor in lots of crazy things. But it's just an expression, but it does bring in challenges for patients and families, especially if we can't figure out what's going on. A lot of times, the demented patient who has delirium or is acting strange actually has an infection. And I'm sure some of you have experienced that, where you couldn't figure, why is my parent acting or loved one acting like this? And it ended up being some type of UTI or pneumonia. So it's challenging when you look at this grid and say what experiences you lived with if you're caring for someone with dementia. But just, I like what Andy said, the takeaway: behavior is a communication tool for them. Next slide.
So yeah, I mean, there's dementia's because I think most patients live with it so long. There's additional challenges other than the physical, right? There's an emotional component of this. There's challenges making healthcare decisions or with yourself or for another person. Um, you know, boy, my grandmother lived a long time with dementia, and I saw the tension it built up between my father and my aunt, his sister. Different levels of understanding within the family of what the illness is, how it's going to play out. Um, there's always the worry about isolation and not feeling like the caregiver's included in part of the healthcare team. Um, there's concerns about affordability of care because it does go on for so long and requires such an intense care amount of caregiving. And it's really, look, we have a healthcare system right now that really doesn't rise up to provide a lot of
Correct.
support for care in the home.
Correct. Or long-term care.
Yeah.
And especially for custodial things. I mean, medical insurance covers medical stuff, but not custodial needs like helping people go to the bathroom and bathing them and stuff like that, right? And that comes into play when you have someone with living with dementia who needs that level of care and support. The thing that I think is so important to try to mitigate some of these things is try to have conversations about what people would want, like goals of care, advanced care planning conversations long before your loved ones get sick. Like, I am relatively young. My joints don't know that I'm young, but I consider myself young. And I've already had conversations with my son about what kind of care I would want when I can't speak for myself. I think family conflicts, affordability, all of that comes into play when the conversations aren't had up front, and we can now not ask the demented patient what they want, right? Or we haven't talked about, hey, if mom or dad gets sick, or if auntie gets sick, who would they live with? Where can they go? Like those types of things, so that you can start processing them as soon as possible, is so important, but they're not common conversations we have over Thanksgiving dinner. And so it brings about a different layer of challenge. These are more like social layers of challenges than the clinical or physical things that we saw in the last slide.
You can go to the next slide. And as you can imagine, you've most of your caregivers, you've lived through this. Our healthcare system does not do a good job rising up and meeting these challenges. We can go to the next slide, and I'll just say we are very disease focused, targeted healthcare system that focuses on the illness and really shortchanges quality of life. And so, palliative care tries to step into that void because the belief at our core as palliative care teammates and providers is that our health system needs to do better for patients that are, living with, illnesses for years. So again, we're very sick care and technologically driven. We're always looking for cure, which I don't necessarily think is a bad thing. but there's a reality to face that not all illnesses are curable, but we still live with them for a long time. So, palliative care, we're lucky, we get training on pain and symptom management, communication skills, supporting people socially and psychologically, and getting them resources to help them financially to get guidance financially on how to navigate the system. So, we try to fill in the gaps where I think our health system it fails us as a community.
And I think because how healthcare in the United States was constructed historically, that's what is inherent to these challenges, right? That's why the healthcare systems do not, can't do better, or struggle to do better. We've come a long way, but we really struggle to do better because of how we historically formed healthcare in the United States. We are within CAPC, just like the Alzheimer's Association, trying to keep education going, community wise and training wise, making sure that our doctors and nurses, while they're in school, get some of this training so that they're more comfortable having these conversations and that our future healthcare can look different. Next slide.
Yeah, I mean, we kind of touched on this a little bit. I mean, people want the disease to be treated. They want to maintain good function and quality of life. They want people talking. They want coordination and connection of care. What does that mean? I don't know. When my dad was sick, he said, I don't need another doctor. I just need two that are talking to each other. And I think that's part of palliative care's role is coordinating care between the many doctors that may be involved in someone who is living with dementia. Because very rarely does that happen in a vacuum. Sometimes there's kidney problems or heart problems or breathing problems that go in it alongside the dementia. So trying to coordinate that care and a point of connection for patients and families and caregivers. Like when you're having a crisis, knowing that you can pick up the phone and talk to somebody who's going to do more than maybe tell you to dial 911. 911 to me is not a plan, um, especially in an illness where we kind of know the trajectory. Yes, there's ups and downs for everyone, but we know that this is a progressive disease, that there'll be different stages. There's early stage, there's mid stage, and there's later stages of dementia, and we can anticipate a lot of that. And so palliative care can serve to be that connection of care for the patient and caregivers, and then just support to help people make informed decisions. We don't impose our values of what we think is appropriate for care on our patients and families, but what we try to do, and Sharika is one of the best at this, is talking to patients and families in a way that they can absorb the information and make decisions that are aligned with what's most important to them.
I had this patient, Andy, once that said to me something similar, so like what your dad said, stuck with you. He said, people keep coming in here and talking to me and not with me. And I think as everyone, I saw a lot of caregivers on the line that that's why I'm a big advocate for people, because I think the role of the advocate, the role of the caregiver, the role of the support system is to kind of help a patient be a part of the dialogue where we're talking as a medical team with them and not to them. And sometimes it means we have to intervene as loved ones and say, hey, this is what she means, or hey, can we talk about this, or could we consider that? Because people have a right, everyone has a right to really make their own decision, right? To make the best decision on deck for them. They use the medical team's information, like what we know about medicine, and we pair that with who you are as a person, who you are as a family. And that's how you come to an informed decision making. And I think sometimes you need help as a patient doing that, especially the demented patient that sometimes can't speak for themselves. So I think people just want to be heard. That's what people really want.
For sure. We can go to the next slide. Here we go. So, palliative care has a lot of benefits. We address a lot of the things that we've been talking about earlier in this presentation. We try to reduce the amount of distress and suffering for patients. Try to prepare families and especially caregivers for what to expect as the disease progresses. And as Sharika said earlier, trying to upfront some of the decision making so that, the patient who's living with dementia can be part of the decisions even when their disease advances to a point where they're maybe unable to communicate. They were able to earlier on. Um,
I,
addresses
I
gaps.
want to say
Yeah.
that a lot of like helping disease trajectory for dementia is so important. And I've had a lot of conversations with patients and families living with dementia. And the one thing that I think gets lost on people, and I know Andy, you and I've talked about this, is the feeding. Food is love in most of our cultures, and a person living with dementia will eventually lose the desire to eat, and that anorexia will eventually kick in. And so when I have those conversations to prepare people for that, I usually have that food conversation up front with our patients and families to kind of start coming up with a plan. Because what people or patients and families miss sometimes is that not eating is a sign of end stage dementia. And that is something different. I think knowing that before it happens is so important. Seeing that food from a cultural standpoint is love. We make up reasons to eat. In my family, anytime there's a fifth Sunday in a month, we have fifth Sunday dinner, which I swear is a made up holiday for my family, but we all gather to eat. And because it's so tied culturally in such a big clinical outcome in dementia, is important to have that conversation up front. So every caregiver on the line, talk with your patient, talk with your loved one and your family about what happens if your loved one stops eating. It's so important.
Yeah. There's another writing comment, which I think is excellent. You don't have to be a chaplain or a therapist or a case manager to be therapeutic, and that medical training needs to be updated tremendously across the board and
Mhm.
colorized, I think is the word, or decolonized. I'm not sure what that means, but I agree. I mean, to the write-in person, I think Sharika, we view caregivers as part of our team. At least I do. When I'm taking care of a patient, I mean, if there's a caregiver that's super involved, that input from that caregiver is as important as anybody from
Is
the team.
invaluable to me
Yeah,
because to me, the patient's family and care team knows the patient better than I do. I know medicine, but I don't know the person. And I really strive to match medicine with who a person is. Like I've had patients say, my mom gets very anxious when you say certain words. And I'm like, what is the other word that we can use? I'm not offended because I want to make sure that I'm in alignment with who the person is and I can make the adjustment more than the patient can, right? Or more than the loved one. And I think sometimes we caregivers, medical team displace suffering, meaning we don't want to be uncomfortable. So we displace it to the patient or the loved one instead of making the adjustments ourselves.
yeah, great. We can go to the next slide. Um, well, there's a really good comment here. I'll pause before we go forward. I agree. Often caregivers don't know they are the biggest advocate for loved ones. This is especially helpful if their loved one cannot communicate. Shariq, I won't put words in your mouth, but I could not agree more. I think
Um,
we need to empower caregivers and give them voice and providence in taking care of their patients. And I think healthcare for the most part is starting to move in that direction. I know palliative care is in that direction, and I think we're huge advocates for caregiving. Sharika, you have other thoughts on that?
Every caregiver on this line, you're officially empowered to advocate for your loved one. And I always say be assertive, not aggressive. Try to be kind, but if you feel like you're being unheard, you can get a little bit more assertive in that to protect them, but most certainly feel empowered to do that. I think it's vital. I think it's essential because you guys move with them through different healthcare settings where we don't. And so you have a different perspective and insight. And it's just majorly important.
Yeah, yeah. And another writing comment about the norm in medicine is to sort of be quick to make treatment decisions and maybe even borderline dismissive. I'm reading between the lines here, Michelle. If I'm not reading your quote exactly, but believe me, Sharika and I see um, when we get consults, often we see people have really been put through the ringer in the healthcare system. They've been dismissed or they've been marginalized or, to your point, racism, gaslighting, all that. Yes. Does it happen? It absolutely does. But I think it's a good segue to this slide in that most large hospital systems have a palliative care team. And I would say, I mean, I can't speak for all palliative care providers and all palliative care teams, but I think it's in our DNA to be patient advocates and caregiver advocates. And I think um, while we can't change the sort of traumatic experiences people generally have in the healthcare system by the time they get to us, we can be a safe haven. Sharika, I'm sure you have strong feelings about this. I think I view that as one of our major roles.
Yeah, and I think it is a major role of palliative care, just as a whole, which is why I was saying it's invaluable as soon as possible in the care to try to mitigate patients and families from having these experiences by trying to prepare people and do like the forecasting and the disease trajectory, at least um, provoke some conversations and some thoughts. So, with the patients and families to kind of have those dialogues as they go along. But yeah, I think that sometimes medical teams can be very biased and not really aware of their behavior. Some people are, but sometimes it's good intention. It's like the I Love Lucy. It's good intentions, but the way it comes across or the way it comes out feels dismissive and demeaning to the patient and family and like a little disrespectful to them as a culture. And that is an experience. And I don't think it's going away anytime soon.
Okay. Well, I seem to have offended one of the people in our chat, and I apologize. That was not my intention. So, Michelle,
Oh,
I'm sorry. I did not mean to do that. We can go on to the next slide. So, how does caregiving affect caregivers? Well, I mean, I think this slide encapsulates a lot of it. I mean, it is incredibly, uh, man, it's all consuming being a caregiver. And Sharika, I'm going to defer some of the slides in this section to you, having, you just went through this experience with your mom. So maybe you could
so
tell
yeah,
us
I
how it
think
affected you.
I had to get help, even though I was a doctor. My aunt actually moved in with me to help care for my mom, and it was tough for both of us, especially the period of time when they're not sleeping. Like my mom was not sleeping at night, and getting up at the middle of the night and doing all kinds of things. And so we would discover them in the morning. So I ended up buying a bed alarm and all kinds of things. But it kept me up and down at night. It kept my aunt up and down at night, kind of like caring for a baby. And it was kind of rough to get through my work days. Next slide. And so what we know is a lot of times patients and families are not trained to have this level of care or to perform this level of care. And a lot of patients and families experience angst around being suddenly having to care for this person. And even though I was a physician, and so I would consider myself having a lot of training, it still was uncomfortable for me because I was fearful of I'm leaving my mom and is someone going to mistreat her or if I have to go to work, things like that. So it's important that we understand that some of you may not have been prepared to do this. You may be the only child that's capable of doing it. And so caregiver burnout is a term that we use to describe this overwhelming feeling of being a caregiver, a primary caregiver for someone living with any serious illness, including dementia. And what happens when caregivers are burnout is that usually we see patients go to the hospital more. Patients have to get placed in a nursing home because the level of care that a family member can provide and the level of care that the patient needs sometimes are mismatched. And the nursing homes are usually used to kind of close that gap. I would say that most nursing homes, I don't know if you guys on the line have experienced it, a lot of nursing homes are just suboptimal in their care. It's inherent to the the culture to the healthcare system. So it's important for loved ones, it's important for the patient's family to be as involved as they can when your loved one is at a nursing home, to ensure that the treatment is optimized for the patient. Next slide. So what do caregivers need? They have to be, and they must be included in the care team for what we said earlier. You are the biggest advocates. You're the one that's gonna know when the appointment is next, when it can be, when they can have the appointment because it's usually on your schedule, and have the information. I always strongly recommend that patients, families keep some type of medical record, whether it's electronic or paper, or you can pull up the patient's EMR. It's very important to have access to that so that if you go to a medical appointment, you know what information to give them. It's also important that the caregiver health themselves is addressed and there are no unmet needs by the caregiver. It's akin to putting on your own mask first before putting on someone else's mask. So I've had caregivers that are battling cancer and still trying to be a caregiver and not asking for help. And so it's important that caregivers' health and well-being and the capacity to be a caregiver is assessed and also met. There should be a plan that matches the needs of the patient and the caregiver and reflects it on the medical end and advanced care planning. And then if you need something, like I actually use the Alzheimer's Association, by the way, with my mom. So don't be afraid to get referrals to other services, other medical teams, get educated about the disease. Sometimes people do good in peer groups or support groups. Some people don't. You may need your own therapist. It may be a phone a friend, but make sure as a caregiver that your stuff is being met too. You can go to the next one. Two more, advanced two. Practical tips. Go back one. Yeah. So recognize your own needs. What do I need? And I think the biggest thing is don't be afraid to ask. A lot of us are over stoic for whatever the reason, especially amongst our Black, Brown, Latino communities. We can be stoic. So make sure that you don't hesitate to ask for help. Pay attention to your own health. If there's a symptom or something going on with you, make your appointment with the doctor. Take care of yourself and be okay. Give yourself permission to say this is hard, or I'm having a bad day, or I'm frustrated, or my mom is driving me crazy. Like I would tell people. And I discovered little ways in being honest and authentic. I discovered ways that was beneficial for my mom. Most demented patients seem to receive from the opposite sex. So I would call either my boyfriend, my brother, my nephews to talk to my mom and tell her the same thing that I told her. So if you just be authentic with your feelings, then you can discover treatments for yourself as a caregiver on how to deal with the hard days. And taking a break is important. My sister and I actually switched off and taking care of my mom, and it was helpful. My nieces were the primary caregivers, my 20-year-old nieces. But when they needed a break, my sister got her, I got her. My aunt came and helped. We have a huge family, so we had people. But if not, even if you have to hire a caregiver for 4 hours, sometimes that is helpful to give yourself a break as a caregiver, and don't feel guilty around it. A lot of caregivers feel guilty when they need help or have to ask someone else to help them, but don't feel guilty. You need a break too, and it's so important. Next slide. So one of the things that I used to do with my mom is really exercise with her because it helped her with the dementia. And this is one of those things I kind of discovered when she was with me. She would be in the workout room with me. And then one day I just said, Mom, let's do it together. And I could see her kind of lightening up and smiling more once we started exercising. Her speech got better through the exercise. And so someone put together a video for me. I can't say I did it for myself, but someone put a video together for me that actually went viral on social media. And the tonal, which is the machine I use, actually replayed the video on their website, their social media, and I wanted to share it here with you guys. And that was about, Andy asked me, that was about 2 years before my mom passed. So she passed in July of this year. And this was 2 years before that. And as you can see, she was like walkie-talkie, all kinds of stuff, very, very demented, but still walkie-talkie. And I was very happy to have given her that moment, those months where I saw an improvement in her overall well-being, and in mine, because as a caregiver, when they improve, you improve too. I think that's our last slide.
Yeah,
Any
we
other?
can turn it over to questions now
Yeah, I was
for
just gonna say,
and
I don't know if
are,
something's in the chat.
are we able to unmute for people to talk to us, or do we have to handle all this through chat?
We can have folks unmute themselves.
Sure,
Oh, that
that'd be
would be
great.
awesome.
Do we have anyone with questions?
Hi, yes, I had asked the question in chat about what the how does a caregiver enlist palliative care? Is the only entry point through hospice, or are there other channels?
Oh yeah, no. So I'm sorry, Andy, you
Oh,
go.
go ahead, Sharika, you got this.
No, so how you receive a palliative care referral is through a consult from any of the current doctors caring for your loved one. Palliative care runs concurrent with treatment, and all you need is a referral to the team if there is one in the community, or if they're in the hospital, consulted in the hospital.
Okay, so only through referral from the primary doctor.
Or any doctor caring from your loved one can send a referral.
Yeah, I think not just because of the technical aspect of, you need a referral to be seen by another doctor. I think it's important that the other doctors know that we're involved and invite us into the case, because that's when we can be most effective, when we work side by side with them as well. And so, I always think just ask, just say, I saw this presentation on palliative care. I'm thinking we might be able to benefit a little bit. Would that be something you'd be okay with? And I think that allows the collaboration, I think, to really happen. Don't you agree, Sharika?
Yes. And someone asked about insurance. Yes, insurance covers palliative care as a specialist, a team of specialists, just like your cardiologist, the heart doctor, brain doctor, is in the same vein. So if your insurance covers that, it will cover palliative care. And if you have a copayment or something like that, it kind of is the same thing on the same line. How do you both in order to receive ongoing training on the topic?
I think that was with respect to a previous comment from that same texter, although I'm not sure. I'm trying to interpret it. Might be easier just to come off mute and ask us.
My other question, I'm sorry, I'm not sure whether that's what's being referred to, but I had also asked, Cheryl had mentioned EMR. I didn't know what that meant.
Oh, sorry, electronic medical records. So a lot of electronic medical records now have patient access. And if you are a caregiver, having access to your loved one's medical record is very essential, because then you can log on and see progress notes and labs. And if the patient has to go to a specialist or go to a nursing home, you can log on and share information with them in real time.
Thank you. I'm
No
sorry,
problem.
Sharika. I had called you Cheryl.
I knew you were talking to me, but it's fine.
Thanks so much. And
You're welcome.
I'm sorry you lost your mom. It was a beautiful picture there at the end.
Thank you.
We have a question from Ms. Selman. Ms. Selman asks, what role does cultural humility play in the engagement with patients and caregivers?
So I'll let Andy answer on his own, but for me, it plays a huge role. I think our intentionality is how we make medical decisions, and intentionality, our why we do something, is based around our culture, beliefs, and values, which are very fundamental to people. And so it plays for me a big role when I'm having conversations with people. I usually get to know them first, which includes their culture. Um, Andy.
Yeah, I mean, certainly it's one of the biggest challenge I think clinicians face is, one of the earlier comments about, trauma. I know Sharika, trauma-informed care is near and dear to your heart, and you helped us assemble our toolkit for training other clinicians on the impact of trauma and how it affects people. And I think, it's a clinician's responsibility, the best that we can, to really understand people's lived experience, inside the healthcare system and outside of it, and to use whatever resources we can to try to connect with the patients in a way that respects their culture and their learned experience. And I learned a lot of this working with you, Sharika. I mean, we used to collaborate a bunch when we worked in the same healthcare system around making sure that as a team we were meeting people's needs. And I think that's one of the real benefits of having palliative care be a team based modality of care, is that you have others that you can call on that have maybe shared similar experiences to others, or that you can at least pull from their
Yeah.
experience to help you.
And it's easy for us to understand patients within our culture. Cross culturally, research shows cross culturally is challenging for patients, for medical team to understand. And so I think just know that as a caregiver, if you have a physician or a medical person that's across cultural from you, they may not understand you. It's not intentional. It's just people don't, even cues, nonverbal cues are hard to understand cross culturally. And the other thing, I know Andy and I had a big talk about this when we discovered it, was racism is trauma. And so that thing comes in too. I mean, that's part of someone's culture, is part of someone's lived experience. It can make people hesitant about trusting the medical team. All of that is true. And so knowing that is important and not trying to diminish it or be shamed by it. It's what it is. And knowing how to act around it is so important for the medical team and patients and caregivers.
Yep, great.
So much. And we have another question from Ms. Elman Fisher. Thank you for your questions, Ms. Elman. The question reads, how do you build capacity to do your work to mitigate burnout, vicarious trauma, and moral injury, as well as explicit and implicit bias?
We call each other. That's how we mitigate. No, I think the one thing that, Andy and I have, like we said, we've known each other over 10 years now. And the one thing that I've learned from Andy and from Dr. Esch is really to be authentic, like to own my stuff and not beat myself up about it, to improve where you can improve, but not carry the weight of everything that is wrong with you, because you're not perfect. And a lot of doctors are type A's. We want to be perfect at everything we achieve. And that is crazy. That's all ego. And Andy helped me kind of manage that so that I'm not burnt out. He also taught me to give myself permission to be sad. In caring for people living with serious illness, there are some sad days. And, Andy was my boss, and he would be like, go back to the office, sit, take a break, cry, whatever you have to do. He would when it got really bad, he would be okay with the team even going home. And I think it's important to know when you have to do that balance, so that you don't burn yourself out. And then it is true. If I get, even now to this day, if I feel strongly about a case or something is bothering me, I do still call Andy and I say, hey, this is what happened. And it's mainly because it's easier to have a conversation with somebody who has a shared experience. And I don't have to go through all the details. And he gets mad with me or gets frustrated with me, then he'll say, this is what we have to do when we do this like rally thing in an appropriate time. Even with this thing with my mom, being a doctor and a caregiver was a challenge for me. And to the point that I said to Andy, you are going to manage this case for me. And I called him every day when my mom was terminal and dying on hospice. I still called Andy every day and said, what should I do here and what should I do there? Because I knew that my daughter instincts was going to be higher than my doctor instincts. And so all of that is how I personally mitigate. I don't mind phoning a friend, calling for help, and being authentic with how I feel.
Yeah, I feel the same way. I think this is challenging work, but I think there's yeah, you find your tribe, right? And Sharika and I, we have each other. Um, same thing. I mean, everything Sharika said about calling me, I call her all the time. Sometimes I'll get the what the hell did you do that for? I get honesty, um, I get insight because we've known each other a long time, and I think there's parallels to caregiving in that way too. I think caregivers, because that's incredibly stressful, incredibly challenging, more so than what Sharika and I do. And so, I mean, surrounding yourself with supports, whether that may be a church group or a community group, or I saw that there were some support group facilitators on this call. I mean, I think you have to build your support network and not be afraid to reach out to them. And it's one of the things that's been so special in my career is having met Sharika early on, and to be able to still have that to navigate this. And I think caregiving is very, very similar.
We can't hear you.
Thank you. Well, thank you so much. We're just at about time, and I just wanted to take a quick few minutes again to share some information about the Alzheimer's Association. But first and foremost, thank you, Dr. Newman. Thank you, Dr. Ash, for taking time out of your very busy schedules to connect with the Alzheimer's Association and to connect with our caregivers. We really appreciate your insight uh, in palliative care. And we are getting a lot of clapping emojis and uh, notes in the chat. So thank you both again for taking the time. We hope that everyone who did attend the presentation found it to be extremely helpful. Again, as I mentioned, one thing that I want to emphasize is that we have our 24/7 helpline. The number is 800-272-3900. It's available for you around the clock. We will have this recording available on our YouTube page under our Ask the Expert series. If you can give us maybe 48 hours to get it up, and I will also be sending more information out via email. So thank you again, Dr. Newman. Thank you, Dr. Ash. Thank you for all the attendees, for your participation in the chat, for keeping us grounded, for keeping us accountable. Your work and dedication as caregivers, as participant of this program does not go unnoticed. And thank you, everyone. We hope you have a wonderful afternoon and a great fall season. Thank you,
Bye,
everyone.
Bye,
everyone.
everyone. Thank you
Thank
for having
you.
us.
Thank you.